It is now my pleasure to introduce our presenter, Dr. Lemming Yu, an MD. He will present gallbladder disease surgical options. Dr. Yu is a clinical assistant professor at Case Western Reserve University of Medicine and board certified in surgery. He received his medical degree from Shanghai Medical University in Shanghai, China, and general surgeon residency at University Hospitals Cleveland Medical Center, along with his advanced minimally invasive and bariatric surgery fellowship. His special interests include laparoscopic surgery of the gallbladder, common bile duct, anti-reflux surgery, hiatal hernias, small and large intestine surgery. Hernias including abdominal wall reconstruction plus endoscopy. He does ETGs and colonoscopies. He has most recently been appointed the medical director of the newly opened Wound and Hyperbaric Center at University Hospitals Geauga Medical Center. Ladies and gentlemen, Dr. Lemming Yu.
Thank you, Luann. Good afternoon, everyone. And so today we're going to talk about the gallbladder diseases and the treatment. And like what Luann said, I'm a general surgeon, and majority of my practice is minimally invasive surgery. That means laparoscopic surgery. So let's start first with common questions from my patients during my practice. So these are the common questions. Patient will ask, where's my gallbladder? What's the function of the gallbladder? Can I live without my gallbladder? Why I'm having gallstones? What are the symptoms of the gallbladder disease? Can you just give me medications to dissolve the stones instead of removing my gallbladder? How long is the surgery? And what's the risks associated with surgery? And what's the recovery after the gallbladder surgery? In terms of the diet, exercise, and when I can shower, and when can I go back to work? I have polyps in my gallbladder, and should I be worried? And I don't have gallstone, but I have a chronic pain, under the right rib cage, especially after eating. Is it related to my gallbladder? Is it caused by my gallbladder? So after this talk, and hopefully I will, address all these questions. And if you have further questions, and you can always ask me. So first, I want to introduce to you and then about some basic anatomy. So where's the gallbladder? And then the gallbladder is under the liver, and actually it's in the right upper portion of your abdomen, and it's under the rib cage on the right side. So the gallbladder is like a pear-shaped sac under the liver, and as you can see right here, so it acts as a storage room and to store the bile, and the bile actually is made by the liver right here. And once the bile is made, and the liver squeezes the bile into the the tube right here, is called a bile duct. And then goes all the way to the small intestine, and this is the most proximal small intestine. Is called the duodenum, and basically helps with the food digestion and the absorption. This is normally, and the opening of the bile duct has a sphincter right here, and so the opening is closed normally, and when you're not eating. And so when the bile comes down, and from the liver all the way to the bile duct, and because you meet the resistance, and the bile goes back up and gets stored in the gallbladder. So but after you eating, the food comes down from this is the food pipe is called the esophagus, and this is the stomach, and the food comes down and to the small intestine, duodenum, and the specialized cells and in the duodenum they can secrete a hormone. It's called CCK, cholecystokinin, and basically it's get secreted into the bloodstream, and then signal the gallbladder and tell the gallbladder, hey, we have a food down here, we need the bile, and please squeeze and some bile into the intestine, so the food can get digested. In the meantime, the CCK actually has another function, is to relax the sphincter and at the opening of the bile duct, and so the valve, it's here, it's called ampulla of the vater, and opens up, and the bile and it gets into the small intestine. So it's a pretty complex and dedicated design for the human body. So, and the first question is, where's the gallbladder? The gallbladder is in the right upper, portion of the abdomen and under the liver. So this is some basic, knowledge of the anatomy. And I mentioned about the function of the gallbladder, and basically it as you can see, it works with the bile duct and the sphincter right here, and to basically to regulate the flow of the bile, and itself it stores on the bile. And the other function and for the gallbladder is to concentrate the bile. So the other thing is what's the function of the bile, and I think I mentioned, and it basically helps in the digestion and the absorption of the food. Is mainly for the fats in the intestine, and so as you can see, this is the small intestine, and the most proximal is called the duodenum, and then goes down. All right, and so the other question is, can I live without a gallbladder? The answer is yes. And the gallbladder is not a essential organ. Is there any common side effects after gallbladder surgery, after my gallbladder is removed? Yes, actually, some patient will have some loose stool and the diarrhea. The reason for that is once the storage room is gone, the gallbladder, and so the bile gets secreted out by the liver and it drips into the GI tract, the intestine, continuously, and the bile is kind of like strong laxatives, and so it can cause loose stool, or sometimes patient even have diarrhea. But the the human body is amazing, and eventually, and the body will be able to adjust to the new condition, and all these will eventually resolve. So what are the common gallbladder diseases? And so this is the list, and then for the common gallbladder disease, and the gallstone and the sludge, and the sludge basically is like a really small crystal in the gallbladder, or sometimes I say like a sand. And for the gallstone and the sludge, they can cause some complications. And one is gallstone pancreatitis, and the other one is it's called the gallstone ileus, and in fact it can cause the bowel obstruction, and the stone can get spilled into the bile duct, and then they can block the common bile duct, and then the bile can get infected. It's called cholangitis. So let me show you why, and the gallstone can cause pancreatitis. And so this is a pancreas, and it's a big gland. It is, secretes the digestive enzymes into the small intestine to help with the food digestion and absorption too. The bile duct and the pancreas, they drain into the common area, and again, it is called the ampulla of Vata right here. So when the stone gets dislodged right here, and sometimes, and then later I have a better picture for you guys, and the pancreas will get inflamed and angry, and it can cause pancreatitis. The pancreatitis actually can be very severe condition, and the people can get really sick, but fortunately, majority of people, they do well. The other thing is I mentioned about cholangitis, and basically what happened is the stone gets dislodged in the body right here, and the bile cannot get into the small intestine anymore, and then they back up, and the bacteria can grow and they can make patient really really sick, and actually it is one of the medical emergency that needs to be addressed immediately. All right, and so these three, common complications associated with the gallstone. Oh, actually, gallstone areas. And what happened is the large stone, they can, and we can get inflamed, and these two structure can get, adhere to each other, and then the stone can erode through the gallbladder, the wall, and into the intestine, and the large stone can actually block the intestine. Um, the other one is called cholecystitis. That means the gallbladder is inflamed and even infected. The gallbladder polyp and functional disease of the gallbladder, and cancer can happen in the gallbladder as well. So the so why I have gallstone. Actually, gallstone is not uncommon. It happens in about 10 to 15% of the adults. Um, the explanation for why I have gallstone actually is not that simple, but the research showed that it has something to do with the balance between three components of bile, and the one, I don't know whether you guys will be able to see, and the one is cholesterol. The other one is lipid, and the other one is bile salts, and so basically, in order for the bile to remain in liquid form, the adequate ratio of three components needs to be maintained at the certain level. So as you can see, and so this is a shaded area, and at this small area, the cholesterol remained liquid form, but it's super saturated. And under this area, and the bile, and there's no solid components precipitate out, and the bile is a liquid form. And beyond this small area, and the cholesterol will precipitate out, and then form the stone or crystal, or you can call them as sludge, and various tiny stones and like sands. So this is the and the specimen, and this is a gallbladder, and then as you can see, you have the gallstone, and um, like that. And but this is just one type of the gallstone. Um, so again, and in order to explain why you have gallstone, it's not that simple, and it has it's associated with many risk factors, and some with diet, and so basically it's the diet, like a lack of the vegetable protein, and not balanced diet, and you know, and I mean, most of Western diet, I would assume, and lack of the, you know, unsaturated fats and the nuts, and has increased the risk for the gallstone, you know, development. And also it's associated with the age. Normally, you know, when the patient is older than 40 years old, and it's kind of like a, you know, risk factor. But since we have more children, and actually they are have problem with obesity, and we see, you know, the gallbladder problems in that age group as well. Actually, I operate on the, you know, children, and at the age of like 13 or 15, and so that actually, unfortunately, is not that uncommon anymore. And the gender, the female tend to have, you know, gallstone more than male, and obesity, and the ethnic group, and Native American and the Latin American, you know, descent, they have increased risk as well. The high cholesterol, and I mentioned before, and also certain disease, you know, including Crohn's disease, and history of stomach and bowel surgery, they kind of disturb the metabolism of the bile, and then it, you know, put the patient at increased risk for the gallstone formation. The other one is rapid weight loss after, you know, weight loss surgery or lifestyle change, and intentionally. And I see several patients actually. They were on the keto diet and trying to lose weight. And you know, after that, and they have, you know, came to the emergency department, and with gallbladder problem. And I'm not sure at this point whether, you know, that problem is related to the keto diet, or it's you know, the rapid weight loss, maybe both. The other one is the birth control pills, and especially, you know, has the estrogen, and that increase the risk for the gallstone formation as well. And the family history, actually, it's very important that I see, you know, patient, the grandparents, they have a, you know, gallbladder problem, gallstone, and the mother and the siblings, you know, and tend to have some, you know, genetic background as well. The factors actually can decrease risk for, you know, gallstone formation is a vitamin C, and unsaturated fats, and actually nuts. It's pretty good for your health. Vegetable protein, and the physical activity, and you know, statin, which is a medication, and it can lower your cholesterol, and they have some protective, you know, effect for the gallstone formation. So what are the symptoms of the gallstone? The Fortunately, a majority of the patient, they don't have symptoms, and we call the asymptomatic, you know, gallstone. But about 15 to 25% of the patient will become symptomatic, and that means they can have the above symptoms I will talk about in a minute. And so after, you know, 10 or 15 years, or you can say, you know, for the lifetime. Um, for the, you know, this is the common symptoms for the gallstone, and the most common one is a right upper abdominal pain. They normally, you know, I mean, usually, and it goes to the back, or the right shoulder, and they have associated symptoms, and nausea, vomiting, and sometimes bloating. And some patients, they have, burning sensation, behind the breastbone as well. The reason and all the pain for the gallbladder, normally we call this called a biliary colic. What it does is, it comes in wave, and they last for 5 or 10, 15 minutes, and then go away. The Then they come back, and if the stone and still gets dislodged, and the reason for the pain is, as I mentioned, and when you have a gallstone, and when you eat, and because of your body, and secrete a hormone, it's called a CCK. They ask the gallbladder to squeeze and the bile out, and to help with the food digestion. But at the same time, when you have stone in the gallbladder, and the stone gets squeezed out and it gets dislodged, and here it's called the cystic duct. It's the duct connecting to the bile duct and drains the gallbladder. And but the body, with when you have a blockage, the body try to overcome this blockage, and then blockage, and basically the gallbladder, they try to squeeze and squeeze, and and that's kind of like like in wave. When the stone gets dislodged, sometimes can get dislodged backwards, right, like here, back in the gallbladder, and the blockage resolved, and then your pain disappears, and you know um, you don't have pain anymore. And sometimes the stone can get dislodged, and get pushed into the bile duct, and then this can irritate the bile duct, and then you will continue to have pain, and as well. Again, so the pain is at the right upper portion of your abdomen. The other one thing is, when the blockage persist for enough time, and the gallbladder can get inflamed, and the bacteria will grow as well. And then at that point, it's called the cholecystitis. That means the gallbladder is inflamed or infected. At that point, the pain, they don't go out. Normally, they don't go away without medications, and they stay there. And some patient will come in and say, hey, I have this kind of like pain before. It lasts for 15 and 30 minutes, and it goes away. But at this time, and they stay here all the time, and I try to wait and wait, and they don't go away. So that's why I came to the emergency department. At that point, the stone probably continue to block the duct, and then the gallbladder is inflamed. Okay. The other thing is, the gallbladder actually sometimes can be confusing with the chest pain. And some patients, they come and with pain, especially some patients, they have pain at the upper mid abdomen, and they thought they have a heart attack. But after the study, the imaging study, and the workup, in fact, actually they have gallstone, and they have a problem with the gallbladder. The So for the patient, they have symptoms, and then for on the symptoms and above, um, the risk for complication development is about 2 to 3% per year. And again, and the complication and associated with gallstone is, I mentioned, pancreatitis, and small bowel, I mean the bowel obstruction, and then the blockage of the bile duct, and the causing infection of the bile. It's called the cholangitis. Once you have a complication, before, and then the risk for the recurrent and complication is about the 30% per year, and actually, they tend to be more severe. So that's why we, for the patient with symptoms and from the gallstone or gallbladder, and the recommendation is to get treated and in a timely fashion. All right, and so how do we, make diagnosis whether your symptoms is caused by the gallstone or gallbladder disease? And of course, we will ask you the history and then make sure we and have a good, whole picture of what happened to you, and to make sure it's not caused by other problems other than the gallbladder or gallstone. Um, we examine you, and a lot of time you will have some tenderness, and that means some pain when we push in your abdomen and just below the rib cage. And we also do some blood work and make sure your white count, white cell is a infection fighting cells, and that it's not going up. And we check the liver function, make sure the your liver function is okay as well. And then normally we will check your pancreas enzyme as well, as I mentioned, because of the gallstone can be associated with pancreatitis. Basically, that is kind of like severe. I mean, can be a severe condition, and patient can get really sick. Um, we do imaging study. The one is ultrasound, and so this is ultrasound. Basically, it shows two stones, as you can see in the gallbladder. This is a sac. This is the gallbladder, and the surrounding tissue is the liver. The CT scan is a CAT scan. Basically, and this is one example. You can see the stone in the gallbladder is right here, and here is the liver. Um, the some stone they are not shown on the CT scan if they don't have enough calcium, and we call it non-opacified stone. And so and in terms of that, and the ultrasound actually um, can be a more useful, and in terms of the from the gallbladder or gallstone standpoint. The other one is called MRI, and basically is similar to the CAT scan, but it doesn't use radiation. One test we common use is it's called a HIDA scan, and what it does is this is a chemical, and it's radio labeled, and so we inject this chemical medicine, or you can say into your vein, and your circulation will take the this chemical, and the tracer, and into the liver, and the liver will secrete this chemical into the bile duct. And like what I so this is probably a better picture, and it gets secreted out, and because it has the radio tracer, and so you under the X-ray, and you will be able to tell whether the gallbladder is filled or not. So normally the gallbladder will be filled like here, and so this is the liver, as you can see, and this is the bile duct goes down, and this is the gallbladder. Normally the gallbladder will be filled within 60 minutes, and after the injection of this chemical. When the gallbladder is filled, that means there's no blockage, and at the duct right here, and so that almost certain, and then you can say that you don't have the stone and it got stuck in the duct right here. And this is another example. Is an abnormal study, and so as you can see, and there's no filling of the gallbladder, and after injection of the chemicals. So that means, most likely you have a stone gets stuck in there, and it's causing the problem, of your symptoms. And then, okay. Um, so what is the treatment and for the gallstone? And I mean the symptomatic gallstone. That means the gallstone is causing the problems. Um, the medications and it's can be used, and also the shock wave and to break down the stones, and so the stone can be passed out, and it's called the lithotripsy, and can be used. But unfortunately, the long-term result is disappointing. For the medications, and common use medication is Actigal. It will take several months and up to 2 years for it to be effective. And same thing, and for the lithotripsy, and try to use a device to break down the stone. The efficacy is about less than 50%. And unfortunately, the gallstone, they tend to come back. So that means you have a recurrent problem. What I tell the patient is, the stone is causing the problem, but the root problem, and actually it's your one is your gallbladder, and the two is as you can see, the three components, and the equilibrium and of the three components of the bile gets disturbed. So let me. So the non-surgical treatment and is not considered to be a part of the primary treatment algorithm. The surgical removal of the gallbladder offers the best long-term result, and then about 90% of patients that will be symptom-free. The keyhole surgery, laparoscopic, approach is the standard care. Normally, it's a outpatient procedure. That means you have surgery same day, and then go home and after surgery. How long is the surgery? And that varies. I always tell the patient, and the patient's safety is the most important thing. And uh, I don't want to, during the surgery to rush and cause problem. And um, we were taught, the first thing not to do is to do no harm, right? To not harm the patient. But normally it takes about 1 to 1.5 hours, and then for the gallbladder surgery. But it can range from 1 hour to 5 hours, and the longest I did, and it's probably 5 and 6 hours, and the shortest I did is 30 minutes. So it depends on the patient's body habitus, whether they have chronic attack, and which can cause a lot of scar tissues and in the area. And if the patient has a lot of inflammation and infection, and that um, uh, can be challenging as well. So again, and the most important thing is patient safety, and you don't want to rush, and you want to do everything right in the first place. So this is what we do, and this is called the laparoscopic gallbladder removal cholecystectomy. That's a medical term. We make a small incision and at your umbilicus, the belly button, about two centimeter in length, and then we put the camera in there. And then we have three smaller incision, about the one actually less than 1 centimeter, and in the right upper part of your abdomen, and this is the instrument that we use, and then this grasper, and then we dissect out the gallbladder, and this is the artery feeding the gallbladder, and this is the duct. It's called cyst duct that drains the gallbladder into the bile duct, and then this is the liver. And the instrument actually is really thin. It's about like pencil thin, and but like 2 feet long maybe. Um, so use the instrument to take the gallbladder out, and this is like a TV monitor. You can see. This is basically how we do that. I normally and almost always, do a procedure. It's called a canangiogram. What I do is I put a catheter through the, gallbladder and right here, and put the catheter in there and inject some contrast, and then under the X-ray to check the bile duct. And then as you can see, this is the bile duct right here, and this is small intestine, and the drains and then into the small intestine. The reason for that is when you have gallstone, and 10% of the chance you may have a stone in your bile duct. I'm gonna go back to the other picture, and like here. So when you have stone in the gallbladder and the gallstone, and the 10% of and time, and you have the stone in the bile duct right here. You want to, if you have the stone, you want to identify that. And so this is how we see you have a filling defect right here, and right here you can see a stone in the bile duct. Normally the contrast goes freely into the small intestine right here, and for this one, when you have a stone and blocking the bile duct, and then you see minimal contrast there. So most surgeon, when they find the stone, and then they send you to the specialized, I mean the GI doctor with specialized training on a procedure is called ERCP. What it does is they put the scope into your through your mouth and into the stomach right here, and then go all the way to the small intestine, and at the opening of the bile duct. I mean, yeah, the opening of the bile duct right here. And so I mentioned before, the opening of the bile duct has a sphincter. It's called a sphincter OD, and they cut the sphincter and basically make the opening bigger, and so they can retrieve the stone and from inside right here. All right, so it's called the ERCP. I learned a advanced skill during my fellowship training, and with Dr. Peterman, and in Kansas. Actually, he's one of the pioneers in laparoscopic surgery and common bile duct exploration. That means we try, we will try to clear the stone in the bile duct during the surgery if we find one. And basically what we do, we put a catheter through the bile duct, and then remove that, and from here, I mean from above, or push the stone down and into the small intestine. It's a advanced skill. Fortunately, it's kind of like a unique to my practice, because if we can clear the stone, and actually majority of the time we can and clear the stone during the surgery, and you don't need the additional procedure and for ERCP, because the ERCP is a safe procedure, but it does carry some risks. It because it will cut the sphincter, it can cause bleeding, and if the cutting is too deep, and it can make a hole in the intestine, and also that can be, a severe, bad problem. The other thing is like what I need to go back to another picture. Like what I mentioned, and because the pancreas actually drains into, the same, it drains into the small intestine at the same the opening, and the ERCP can irritate, the pancreas as well. So there's a small chance that you may have, it's called pancreatitis post ERCP. Okay. So yeah, this is another, common question, and the patient will ask, what is a potential risks for surgery? So this is the list. Basically, you have, potential risk for infection, bleeding, intra-abdominal injury, common bile duct injuries. They are really rare, and possible open surgery, and again, I always tell the patient, patient safety is my priority. If I during the surgery, if I don't think the surgery can be done safely with a keyhole surgery, and then you end up with a bigger incision. It's about 6 inches, and in the upper right upper portion of the your body, and possible lead for the ERCP, as I mentioned. So what's the recovery and after gallbladder surgery? So again, the gallbladder surgery is a outpatient procedure, but we do, put you to sleep and for surgery, and we do need someone else to drive you home. It's not safe for you to drive back home and by yourself. The pain should be minimal, and normally, I tell the patient, and after gallbladder surgery, after 2 or 3 days, and the pain should be minimal. And if you have, a significant pain and the fever, chills, stuff like that, and then the patient, you will have to call me, and that means there may be something wrong. Also avoid constipation, and because you do need a general anesthesia, and some patients after general anesthesia, and they tend to have constipation. So I will normally send patient home with some stool softener and laxatives, and ask them to to drink plenty of water, fruits, and sometimes prune juice actually is pretty helpful. Sometimes even use animal or suppository to relieve the constipation, but most patients do well. In terms of the diet, and normally light meal on the day of surgery, and then after that you can there's no restriction on the diet. You can eat whatever you want, and as long as you doing okay. No heavy lifting more than 20 pounds for 2 weeks. The reason for that is you don't want because you do have incision, and a small incision, and for the surgery, and you don't want to have hernia at some point, and takes about 2 weeks for the tissue to heal. Um, the other thing is when can I shower? And then normally 1 to 2 days after surgery, and then we stitch up the skin, and with absorbable sutures, and actually it's under the skin, and normally and then we apply the dermabond, which is a super glue, and to close the skin. You don't no need for suture removal, and then you can shower almost right away after surgery. And normally, I suggest go back to work, and at least 1 week after surgery. But I have a patient that they go back to, and normally I operate on Friday, and I have a patient that they go back to work on Monday. So as long as you feel up to it, and but again, no heavy lifting, after surgery for 2 weeks. So there's no need for suture removal. Okay. So the other question, and I got a comment is hey, so patient will come and say, hey, my family doctor did the ultrasound and of my gallbladder, and I was told I have polyp. Should I be concerned? Fortunately, a majority of the polyps are not neoplastic. That means they are not tumor, but they are just some abnormal mucosa. Mucosa is the lining of the gallbladder, and the lipid cholesterol are departed, and so most of the time, and they are benign. And actually, it's not uncommon. It happens, about 1.5 to 4.5% of the gallbladder and examined by ultrasound. That means if you have 100 patients, they sent to have a ultrasound of the gallbladder. About 2 to 5 patients will have the polyps. Depends on this is a little bit of medical, I'm sorry, and but the bottom line is whether you we should do something about the gallbladder polyp is depend on the size of the polyp, and if the polyp is less than 1 centimeter, and that means 10 millimeter, and then if it's not causing anything, symptoms for you, and then you can basically monitor that, observe that, and with surveillance ultrasound. If it's symptomatic, and then the recommendation is to take the gallbladder out, and if it's more than 10 millimeter, 1 centimeter, and the chance for the tumor or even cancer is increased. So normally we recommend to remove the gallbladder. Okay, so this is for the concern of the gallbladder polyps. The other one I want to mention is gallbladder functional disease. So and again, and then patient come to my office and for consultation, and then sent by the family doctor, and they did CT scan, CAT scan, ultrasound. They didn't find anything like including gallstone, sludge, or polyp of tumor, but that they have chronic on and off pain, especially after eating. In the right upper portion of the body and abdomen, and then we do a HIDA scan, and then they actually show that the patient has gallbladder functional disease. So I mentioned before, the HIDA scan, and is a good way to check whether the stone is got stuck in the the duct right here, and the other utility for HIDA scan actually is to check the function of the gallbladder. What it does is so again, so we injected the tracer, the chemical, and the radio labeled chemical into the vein, and the liver gets the chemical gets taken by the liver, and then that gets screwed into the bile duct system and fill the gallbladder. And I need to go back there again. So the chemical gets screened by the liver right here, and screened it, and then into the bile duct, and it gets filled back in the gallbladder right here. Okay, and so this is the the chart, and then basically shows the gallbladder is filled, and after injection, it takes about 60 minutes, and for the gallbladder to be filled and complete the field. And then at this point, you inject the CCK. If you remember, it's a chemical and hormone, and can ask the gallbladder to squeeze and contract. And then after your injection of the chemical, and normally about more than 40% of the bile gets squeezed out. For this patient, only like 30%, as you can see, and it's close to like a 75 here, right here. Gets squeezed out. So that means about 30%. So this patient then has a condition. It's called gallbladder dyskinesia, and basically, that means the function of the gallbladder is below the normal level. And there's another, condition is called the hyperkinesia, and that means kinesia means movement, and dyskinesia means not moving, right? So for the hyperkinesia and kinesia, actually, the gallbladder and the squeeze too hard, and and that is causing the problem as well. So after the surgery, actually, a majority of people, they do well. And I have several patients, and actually for the past year, and they have the gallbladder functional disease, and after surgery they do really well, and they are so happy. They can they can eat and the food and again, and they're so happy. So that's for the gallbladder functional disease. So I guess those are the common, conditions and disorders, and for the gallbladder problems. Yeah, as Luann mentioned, and we just opened up was center for wound care and the hyperbaric medicine, and it's a brand new center, and we have wound clinic before, but now we're expanding for the wound care. We in our center, we treat almost every all types of wound, and you have a venous wound, pressure ulcer, diabetic foot, you have ulcer, and then you have like a surgical wound, and some patients that they have radiation for cancer treatment, and then that can hurt the skin, tissue, or even bone, and we treat those too. The center will offer advanced treatment, and we do a multidisciplinary approach. That means we have multiple different specialties, including vascular, service, vascular surgery, podiatrist, plastics, infectious disease, and working with the physical therapy, and for the to take care of our patient. And we work really closely with the primary care physician, and then actually it's very important, and to basically address the wound problem from different angles. We do, surgical debridement. We use wound vac for the non-healing wound as well. If the patient has edema and has a venous problem, we do the compression therapy, and actually it's very important, for the wound healing as well. We offer skin substitutes and even growth factors, and to promote the wound healing. The last thing actually is we have a hyperbaric oxygen therapy, and we have 2 chambers, and I believe that's this is the chamber. That is one of the I think it's on the east side, and then this is the only hyperbaric oxygen therapy in the area. So So that's it. And thank you. And if you have any questions, and I would be happy to answer.
Thank you, Dr. Yu. This was a great presentation and a great deal of information. We do have a few questions, but we only have a few minutes, so I'll go through them quickly. Does anything need to be done for the presence of gallbladder sludge and a 2-millimeter polyp? And will these progress into something more concerning over time and require gallbladder surgery?
And so again, for the the sludge, if the patient is asymptomatic, and you can just monitor that. And for the polyp, it's really like 2-millimeter polyp is very small, and if they don't cause any problem or symptoms, and can just monitor that.
Okay, and if I have a stone and it's not causing a problem, is there anything I can do to reduce the stone?
Like what I told and mentioned, and you can try the Actigall, but for the asymptomatic gallstone, even you have a large stone or multiple stone, and normally we just monitor that and without doing anything.
And then we have one last question. I had my gallbladder removed and had to have an ERCP. Following the procedure, I continued to have gallstone symptoms, and I was prescribed a medication, Urcididol, which I take twice daily. If I do not take it, I get intermittent sharp pain, not constant, but periodic. What causes these symptoms of having gallstones when you don't have a gallbladder?
Sometimes and after ERCP, and a lot of time they cut the muscle. It's called the sphincter, and sometimes they even put a stent in there, and those sometimes can make some irritation to the bile duct, and even you don't have the stone, and irritation in the bile duct can cause similar pain, as of the gallstone, and again, about 90% of the people, they have a symptomatic gallstone, and after surgery they are symptom free. The other thing is sometimes after the surgery and the gallbladder surgery, and sometimes they can form some adhesions. And I do have a patient, after the gallbladder surgery, they have adhesions and in the area, and I mean, we do a bunch of workup and studies. There's no a clear reason and to see what's caused the pain, and then we do, it's called the exploratory diagnostic laparoscopy. That means we put a scope camera in there, and actually they have scar tissues in the area. We release free all those scar tissues, and then the patient is doing much better after that. So it can be multiple reasons for that.
Thank you, Dr. Yu, for your
No.
time and sharing this important information and answering all these great questions we received today. Just a couple of reminders to the attendees. We will be emailing you a link to our website to view a recorded session of today's webinar. Also, to schedule an appointment with Dr. Yu, please note on the slide, the phone number is 440-901-5826, or you can visit uhhospitals.org, find a doctor. This will conclude our session for today, and I thank you all again for attending, and we hope you join us for future webinars and virtual events in the future. Enjoy your day, please stay safe.
Luann?
Yes.
Can I mention one more thing? And actually, I do have office both in Chardon and the Solon, so that can be a little bit more convenient for the patient. And so for the 2 locations, I guess.
And also, Dr. Yu, you forgot to mention that you speak English and Chinese, just in case anyone needs it.
Sure. And I provide a free translation too,
Great, thank you.